when you can see my slides?
Not yet. There you go.
Okay, we're in business. So again, good morning, everybody. I hope everybody's having a good morning so far. Today, I want to talk about the learning health system, which is something I think a lot of people have heard about, and then specifically tie it to a standard called FHIR. So specifically, I'll go over a little bit about the learning health system, how it relates to FHIR. I'll talk about an initiative called Adapting Clinical Guidelines for the Digital Age, as well as another initiative called Making EHR Data More Available for Research in Public Health, also called MedMorph, and talk about how all of this could work in the real world. So to start with the learning health system, in terms of what we have today, we have a lot of different entities and groups doing things related to data, evidence, knowledge, and action, but they're a little bit disconnected, don't quite fit together well, and sometimes don't feed well into each other. So where we want to get to is a place where all of these different aspects of the learning health system actually work well together. So you have, for example, the evidence smoothly feeding into knowledge, the knowledge being actionable in practice, the actions taken in practice producing data. The data then can be analyzed and produce more evidence and start the cycle again. So here's another view essentially of that same learning health system. And one of the themes I'll hit on a little bit throughout the presentation here this morning is that there are a lot of different cycles that can be called the learning health system. And in this case, again, we've got the evidence, knowledge, action to data cycle again. In order to help connect all of these pieces in the way that I just described, you really need a good way for sort of the data to flow around the cycle. And so this is where this standard called FHIR, Fast Healthcare Interoperability Resources, comes into play. So I'll show you at first how it can be used in adapting clinical guidelines for the digital age. So to start with, in order to really produce a new way, a more effective way to get guidelines into practice, CDC started an initiative in 2018 called Adapting Clinical Guidelines for the Digital Age. And we kicked it off with something called a Kaizen event. Kaizen is a Japanese word that means change for the good or continuous improvement. And what we did is we brought together a lot of different partners in order to really look at how we do guideline development and implementation and figure out how it is that we could make it work better. And so we took this approach in order to incorporate all of those relevant perspectives from the outset. And not do it in sort of a siloed approach, because that's been one of the issues, this siloing or stovepiping among all of the different groups across that continuum. And so it also contributes to transparency and better buy-in, and in particular, understanding between different groups. So for example, we never really had guideline developers working directly with informaticists prior to this. And so it was a bit of a learning curve to even talk to each other, because if you think about the types of ways that you communicate to another scientist working on a guideline, it's pretty different than the way that two informaticists might talk to each other about developing code for software or defining terms in very specific ways. So we've been working together since then and developing a new way to develop and implement guidelines. The process we've called the integrated process because I'll show you in a little bit, it really flips on its head the way that we've normally done it in a very sequential linear way. So one of the benefits is that it can help facilitate that translation and dissemination and speed up the use of the guidance in patient care, which is ultimately the goal. We want the best science helping guide our patient care. And in this initiative, we've got some ongoing collaborations. The standard FHIR that I've mentioned, we've actually developed a specific part of that standard for computable guidance, and it's an international standard. So that helps facilitate our partnership with the World Health Organization. So this is definitely something that's gone global already. And we're working on multiple manuscripts in order to help share this information. I mentioned that we brought together a lot of different groups, and I'm not going to read this slide to you, but I'll pause for a little bit so you can have a chance to take a look at how broad the representation was. The photo in the top right, by the way, is from that Kaizen event I mentioned. And you might actually notice somebody in kind of the second half of the picture that might be talking to you later this afternoon. So these groups, like I said, didn't typically meet together to help solve some of these issues. And these issues have been challenges for a really long time. And as a result of coming together, we started to see things that you couldn't really see without looking at the whole process holistically. So here's what we saw. In the current state, similar to that very first slide that I showed you, it was a very sequential and siloed process. So we would have guidelines being developed, then being disseminated, and having about tens to hundreds of translations happening into clinical decision support, which then may even be further translated to get into patient care. So for example, if you had an EHR vendor translating the guideline into clinical decision support, and then each of their clients, some of you guys perhaps, translating it further into their clinical workflows, you had this very sequential and siloed effect there. And if you think about the perspectives that are needed in order to make that happen, not only do you need the guideline developers producing the guidelines, but you need communicators disseminating, you need the informaticists to do those translations into something computable. You have the implementers actually getting them into the clinical workflows. And if you're lucky, you have some form of evaluation. What we found was that evaluation was actually very, very inconsistent. You might work on clinical quality measures. You might have some that you look at internally for quality improvement, or you might have some that you report on for regulatory purposes. Whatever the reason, frequently these are considered somewhat separate from this process and generally aren't part of an evaluation. So again, what we saw was inconsistent or non-existent feedback loops. So it kind of broke up that learning health system. What we then came up with as a new way forward is this proposed parallel and iterative future state where you have all of the perspectives required at the outset, and you have concurrent guideline development, translation, and implementation with early engagement and iteration. So as the scientists are producing the actual guideline, you have informaticists working in parallel, translating them into the computable tools, and you have implementers informing of various implementation challenges that they might foresee so that could help evolve what's being developed into something that actually is a lot more practical. And so you also have communicators and evaluators involved so that they can plan ahead for how to disseminate and plan ahead for what needs to be evaluated. And in that way, you're better prepared once the guidelines are ready to release. Then we can release them as a package where you not only have the guideline, which is your typical, if you think about like journal articles or something posted to a website in a PDF, you can have that alongside the tools that can help implement, like clinical decision support, clinical quality measures, and so forth. And by doing this, it should get to patient care a lot more easily, quickly, accurately, and consistently, and should help consistently close that feedback loop if we already have evaluation baked into the process. So I'll do my best to say this as non-technically as possible, so feel free to ask questions if there is something that I need to explain further. But in order to really translate guidelines into executable clinical decision support, it kind of has these different knowledge representations, which are L1, which represents the narrative. Again, that's your typical peer-reviewed journal article or PDF on a website. Then they get progressively more structured So you have L2, the semi-structured form, which is things like flow diagrams, decision trees, inclusion-exclusion criteria, perhaps, and other similar formats that describe the recommendations for implementation and are human readable, but more structured than the narrative. Then you've got L3, which is even more structured. So now we're talking about a standards compliant specification that encodes logic with data models, terminology, code sets, value sets. It's basically something that is ready to be implemented, for example, within an EHR, but it's not yet implemented. So this is a computer readable version of that guideline. And then finally, you have L4, which is the executable version. So this would be that full-fledged clinical decision support that's implemented and used in a local execution environment like your EHR. But it could be available in other ways too, like web services or something called a Smart on FHIR app. There's different ways that it could actually be implemented. So I'll come back to this a little bit later, but what I wanted to then get to is back to this notion of that learning health system being in different formats. So in the clinical quality world, there might be something like this clinical quality life cycle, which I'm not going to describe in detail. I just want to point out that it's that same learning health system cycle we talked about before. And it's really relevant in this realm of computable guidelines because it's really important to make sure that we can take evidence and easily translate it into the knowledge, which then becomes more actionable in practice. And that's really what adapting clinical guidelines for the digital age is about. But it really does take this whole learning health system to make that work, because ultimately you need to be able to produce the data and analyze it and get more evidence to be able to update guidelines as well. So in order to make all this happen, just going back to that FHIR standard that I mentioned earlier, there's an international standards development organization called Health Level 7 or HL7 that produces the FHIR standard. And within that, there's sort of these subcategories of the FHIR standard, and I listed them here. I didn't define them because it's not as critical for you to know what they are, but I'm happy to define them later if you would like. The point is that each of these little boxes that you see here have some piece of this FHIR standard that defines how you do different parts of the cycle. And in doing that, it really is a little bit like that initial picture that I showed with the FHIR standard really helping facilitate that entire learning health system cycle. And so here's the part that's directly related to computable guidelines. It's called FHIR Clinical Guidelines. It's been nicknamed CPG on FHIR for Clinical Practice Guidelines on FHIR. And again, it's an international standard that helps facilitate or define how you can create these computable guidelines. What's important here is that you can use it in practice in this way. So again, the knowledge levels become more and more structured. You could start with the first knowledge level, the PROS recommendation. However, this isn't something that's necessarily linear in the way that it's sort of showing on the screen. Some of these things can be developed in parallel and really kind of iterate with each other. But just to be able to fit it on the screen, I'm showing you the PROS first. And this is an example from CDC's opioid prescribing guideline, one of the recommendations. And I'm just going to take it through all the way to being in patient care. So if we go to the semi-structured version, this is where we have flowcharts, definitions, functional descriptions, and similar products that are more structured than the PROS, but not quite computer readable. But then we also have the L3, the structured format, which is computer readable. So these are the terminology, data elements, logic, and ultimately the computable recommendation. And again, I've got a link at the bottom there. You should be able to get the slides at some point and go to the links if you're interested in seeing these in more detail. But that bottom link has both the semi-structured and structured versions that you see in the tiny thumbnails here for that same recommendation. And then finally, you would use all of this in order to be able to execute in an EHR. So if you wanted to actually apply the recommendation in practice, this would be executed in your EHR and be able to pull up different information, pull together different information in order to help facilitate shared decision-making with the patient. And so this is actually the most critical part of this concept of a computable guideline. So rather than having this narrative that many different people translate potentially in many different ways and may not quite fit with the initial intent that the guideline authors had, if you have the translation done in parallel with the authors, you have a very faithful representation of the guideline in a computable format that can then be put into many different ways of executing. So just as an example, we talked about clinical decision support can be based on this computable guideline, but from that same computable guideline, you can also develop clinical quality measures, and you can also create things like electronic case reports. Essentially, the computable guideline functions, if you think about it like kind of like a Lego figure, you can pull up the same pieces and implement it in that version. So that's really what the formats on the right can be based on the computable guideline. And again, these fit right into that learning health system cycle. So clinical decision support is part of the knowledge to action part of the cycle, and clinical quality measures and other forms of data collection are part of the data to evidence portion of the life cycle. So now I'm going to transition to the other initiative I mentioned, making EHR data more available for research in public health, or MedMorph. MedMorph is a project funded by the Patient-Centered Outcomes Research Trust Fund, which is through the Department of Health and Human Services Assistant Secretary for Planning and Evaluation. The total project timeline is 3 years, and we're about 2/3 of the way through. Need better ways to get data from different EHRs without posing additional burden on healthcare providers. I bet that last part is something you guys care about quite a bit. So I'll hopefully be able to explain to you why it is that this approach can do that. So our goal was really to create a reliable, scalable, generalizable, configurable, and interoperable way to get the EHR data for multiple public health and research use cases. And so we went about developing a reference architecture and demonstrating a reference implementation. Essentially, a reference architecture, you can think about it like a blueprint. It's sort of this template that helps explain how you can move the data from one place to another in a standardized way. And then in order to help show how to do this, we've developed implementation guides, also referred to as IGs. So this is the reference architecture we developed. I'll go through kind of an example on the next slide, but just to say that the point of this is to create a single way, or a common way, I should say, that is flexible. So it does allow for a little bit of difference based on use case, but it shares this architecture across different use cases so that, for example, if you're reporting to a state cancer registry, or you're reporting to your quality, if you're reporting quality measures for regulatory purposes, or any number of requirements you might have, you can do it through this same method, and it's automated. So it's automated by using those workflows that you see there on the right. I'm not going to go through them in detail per se, but the workflows seem to be common across a lot of different use cases, and they're common both in public health and research uses. And by aligning even those two things, it really helps share data in a way that doesn't increase burden, and in fact may decrease the burden you already have. The key is this backend services app, which essentially acts like a router between the EHR and wherever the data is getting sent. It knows what to do because those who are receiving the data author knowledge artifacts. These are things like value sets or trigger codes. It can even be algorithms that kind of live, they live in this knowledge artifact repository, so they get deposited there when they're developed. And then the knowledge artifact repository informs the backend services app that something is available, and it's telling it what it needs, so that when when something gets done in the clinical workflow without needing anything beyond what you document in the clinical workflow, it can find it, package it up in a report, and send it in an automated way. So there's no human interaction required. It could also do this through a trusted third party, like a health information exchange, for example. So it doesn't even have to go directly to the endpoint if there's some other path that a particular use case might need. And so just to kind of show this in another slide here, again, we have the receiving organization. So that could be a public health agency, a research organization. It could be a medical society. It could be a regulatory agency. You can fill in the blank with the data repository there. But any of those could author knowledge artifacts. So in this example, let's just say they authored some trigger codes that are essentially value sets that are needed in order to trigger a report. Then once the knowledge artifacts are placed in the knowledge artifact repository, again, it notifies the backend services app. Then there's a subscription created with the EHR. And so once the provider updates the EHR with information that hits one of those trigger codes, kind of this cascade of events happens that pulls the data out from the EHR, puts it together in that report, and then again sends it to the endpoint. So if, for example, it's your state cancer registry or a healthcare survey that's going to CDC for the National Center for Health Statistics, then it can go there without ever having anybody enter additional data. And then finally, there would be some kind of notification back to the backend services app, which then would go back to the EHR to notify that the report was received and was appropriate, or it was the appropriate information was sent. So why use this approach, this MedMorph approach? Well, you can think about it kind of like a car being the data source, and in this case, the data source we focused on to start with is the EHR. You can think of something called application programming interfaces, or APIs, which use that FHIR standard and kind of sit on top of an EHR. You can kind of think about it like a gas pump on the EHR, where the data is the fuel and it helps pull the data out and put it into the data flow to ultimately get to the endpoint. And the way that it knows how to get there is how it's described in an implementation guide. You can think of that like the GPS. And so it helps do this in a standardized way across different EHR platforms, across institutions. Really, it helps implementation in a consistent way and in a portable way. So if you think about an example where your organization might switch EHRs, you wouldn't have to redo a lot of this work because you can just move it more easily to your new platform. It's not super customized so that it creates this rework that's necessary. It also really helps with onboarding of more sites if you're working together like you guys are in a network and you're trying to do something together. It's just as easy to do with the next site as it is with the first site. So that's a big advantage there. It also provides a consistent description of how to leverage the FHIR implementations in the different EHRs for data exchange. And this can be data exchange with public health surveillance systems, research data marts, regulatory organizations, and so forth. And so what we're aiming to do is really transform the health data landscape using the FHIR standard. Right now, we've basically got this kind of spaghetti look of highways with these multiple different methods and approaches that we're using. And if we use something like MedMorph that's a common method and approach, we should be able to really streamline that traffic. So this brings me back to the learning health system and how it can work in the real world. And so I just gave you 2 examples of initiatives that really help facilitate the learning health system. I'll also mention one more piece that I'm not going to go into a lot of detail, but just to show how all of this can work around the entire learning health system using the FHIR standard. So if I bring up The adapting clinical guidelines pieces that I mentioned to you, where we have the FHIR component called CPG on FHIR, it really helps facilitate the evidence to knowledge and knowledge to action part of the cycle. Then MedMorph can pick up from there and be able to take the data produced from the actions and send it to the endpoints that ultimately analyze and produce evidence. There's another related initiative called evidence-based medicine on FHIR that does essentially something similar to adapting clinical guidelines or CPG on FHIR, but it does it for the evidence component. So if the evidence is already in computable form, if you go back to thinking about the Lego bricks, you can rearrange the evidence Lego bricks into the guideline Lego bricks and put those together, which can then be rearranged for clinical decision support, quality measures, case reports, and so forth, then be able to facilitate the data moving to those endpoints that do the analysis and start the cycle again. So this is how it would work in the real world, ultimately helping us achieve that learning health system that we keep talking about. And that is all. I would be happy to take any questions.
Thank you so much, Maria. You have a very nice way to simplify such a complex system. Do we have any questions? Yes, Rima.
So lately we've been hearing more and more about UDS 2023 and how this data is going to become more patient level. And I'm just curious, have there been thoughts and considerations and plans on how this can all connect with, finally we'll be able to get more precise data for patients?
Yes, so everything I described is at can be at a very pretty granular patient level. So for example, the computable guideline would apply for individual patients in the form of clinical decision support, for example. So you would have something that allows your workflow to pull specific patient information, combine it with a recommendation, and produce suggestions, for example, that allow for shared decision-making for that specific individual. Likewise, in MedMorph, it can do it two different ways. So it can be on a case-by-case basis. So it can be patient by patient that gets reported. So if you think about case reporting to a public health agency, as soon as there's something that would trigger a case report on an individual patient, that would get reported like with just the one patient. But you could also do it with a population. So if you're reporting, for example, to the UDS, you could do it with your population of patients, and it could pull all of those together almost like one big report and submit it that way using the same standard. Did that answer your question?
She said yes.
Great, thank you.
Another question from Dr. Kay.
Hi, thank you for that presentation. It was great. I wanted to ask the information you shared about the MedMorph concept. It sounds really exciting, but it also seems to parallel some of the work that's being done currently with CCDs and the HIE. And so I'm wondering if the idea is to create something in parallel to or to tap into the work that's already being done with state registries.
Yeah, so the CCD standard is also part of the same HL7 organization. What's happening is the standards are evolving. And so FHIR is the standard that can help do some of the things that CCD can't do. And so it's not, while CCD isn't going away right away, eventually it'll sort of phase out and FHIR will become the standard that's used because it has more capabilities. So for now, it's done in parallel, but eventually it will phase in.
Thank you. Any other questions? Bernice, do we have anybody virtually? Any question virtually?
No, we don't.
All right. Well,
you have
thank
any
you so much.
questions?
No, you did a very good job.
Well, great. I'm glad.
Great.
as I mentioned, everybody can get the slide. So if you do have any more questions, I've got my email address on that last slide. Thank you for having me today. I hope you guys have a great
Thank you
meeting.
so much, Maria. Thank you. Thank you.